The doctor-patient relationship is the cornerstone of good medical care. Good communication improves accuracy and efficiency of clinical practice, as well as patient satisfaction. During the medical interview, we know that doctors interrupt early, seek specific information, and struggle to effectively respond to emotions. This leads to the doctor commonly missing issues that are important to the patient. Communication skills are not innate, but can be taught and learned. What do our clinicians think about communication and CPR decision making?
It's not easy to just encapsulate how to communicate about end of life, but there are two simple things that can be said. One is that you have to know what it is that you're trying to say, and you also need to develop some skills in how to say it. So there's what you need to say and how you need to say it, and those are the two wings of the bird. If you don't have one or other of those, it won't run very well.
I think it's really important that when we just have a discussion, that as a clinician we have all the information when we meet with the patient, so that it's an informed discussion.
I think you have to be sure about who you're talking to. In other words, the patient and whoever else they want there, or family members that are key decision makers to all of this lot. And then the most important thing of all is to open with an open-ended conversation starter. Something like, you must have talked to a lot of people over the last few days. Can you tell me in your own words what you think is going on? What do you think is happening here? I think it's very important that you don't provide yes-no options all the time, and I think it's important that people feel like any discussion about end of life is embedded within a general conversation about the patient's well-being.
We need to find out how much the patient wants to know and be involved in the discussion.
It's extremely important to engage with information and communication skills that are appropriate to your audience.
We know from a lot of research that a patient will communicate emotional content far quicker than they will cognitive and intellectual content. And the important thing in that is that as clinicians, we're not really taught about how to deal with emotions. And really, I think that's the root of why these conversations are difficult or can be challenging.
There are a number of mnemonics out there that you can use, all of which are quite valuable, and I would strongly recommend adopting a mnemonic approach.
Trust, I think, is really important in CPR decision making, as it is with many other aspects of communication. Patients need to be able to trust the technical knowledge that we provide and our recommendations. They need to be able to trust that we have their best interests at heart. And for CPR, they also need to be able to trust that if they have an order to withhold CPR, that we still will provide high quality care, and that doesn't mean they'll miss out.
The main indicator, however, of successful communication, and the main take-home message about successful communication, is that you spend more time listening than you spend talking. You know that you've achieved something when you actively listen to the other person and that they feel actively listened to. And there is a general feeling that if you spend 75% of your time listening and 25% of your time talking, you'll actually be regarded by that person as a successful communicator.
The better our communication skills, the better we will care for our patients. We can emphasise to the patient what will be done before discussing what won't be done. We can then align our treatments to meet the patient's goals of care. Learning communication skills is complex. It requires learning about tools, practicing using the tool, then applying to clinical practice and seeking feedback. The clinician then starts the cycle again, further refining communication expertise. What follows are 2 doctor-patient interviews in the same patient. 2 tools are introduced. Ask, Tell, Ask promotes the doctor to ask open questions to get the patient perspective and their agenda. Then from there, the doctor can build on giving them information that is particular to them and useful to them. Nurse is another tool which assists the clinician to respond effectively to emotions. When reviewing the scenarios, consider what is done well, and what is done poorly. Supportive resources are available to optimise the learning experience. Hi, Mrs. Roberts. Yeah, my name's Nick. I'm one of the consultants.
Hello.
I just wanted to have a quick.
Hello.
Oh, thank you. Yeah. Do you mind if I grab a seat and we just have a quick chat? Look, you're really not well at the moment, and there's something I need to ask you. Is if your heart stops, are you wanting us to start it up again?
Of course I do. Of course I do. Yeah.
Well, the trouble is, it probably wouldn't make any difference. I don't think we'd be able to get it started.
Well, that's nice. Well, you'd have to try, surely.
Well, we could do, but it might put you through unnecessary suffering. So I wouldn't want to do that to you.
Well, how will you know? I mean, what about my family?
Yeah, that's a good point. Well, I guess we could get them in and see what they think. But
Well,
so
yes,
you're wanting us to do it, are you?
get them in, and of course you would try everything, surely.
Okay. Well, we'll keep doing everything we can then, and see
Yeah,
see
I'll
how
fight
you
this.
go.
I'll fight this.
Yeah. Okay. Well, we'll keep going too.
Oh, good. Yeah, of course.
Have we confirmed cardiac arrest?
Yes, we have.
We carry on 15 to 2. Vicky, can you just man the defib?
Sure.
And can you just do a rhythm check for us, please?
Hands up compressions.
Okay, we're still in asystole. Can we dump the charge? Okay, everyone, I think we've had 20 minutes of CPR. We've been in asystole throughout. I don't think this is survivable, so I think we should stop resuscitation. Does everyone agree?
Yes.
Yeah.
Is there anyone who doesn't agree? Okay, can we please remove all the monitors? We'll need to pronounce this lady dead.
To think that dying is failure is going to colour everything that you do. Dying is not failure, it's only a failure if you don't manage the dying process well, and people go into that fearful, in pain, and not clear about what's happening and completely out of control.
Hi, Mrs. Roberts. I'm Derek Ing.
Hello, Derek.
Can I call you Dot?
Dot? Yes, please.
Great. I'll just have a seat and we can have a chat. How are you feeling?
Oh, not bad, yes. A bit short of breath as usual, but yeah, I'll get there.
Yeah. So the breathing's been difficult.
It has been, actually, yeah. But, yeah.
So in fact, I think, we've chatted about the condition quite a bit before.
Yes.
I'm a bit worried that your breathing isn't getting better the way that we would expect.
Well, yes, but it's been like that before. I've bounced back, gone home, seen the grandchildren.
You have, and to your credit, I think you've always been a fighter.
Yes.
And you've always sort of bounced back.
And I tend to continue that way, hopefully.
I hope so too. I guess I'm a bit worried that at some stage, and it maybe even now, that you don't bounce back the way you did. Is that something you ever think about?
Well, yes, I do, actually. It worries me too.
Does it?
I try and fight it.
Yeah, and I think, you certainly do fight it. And I'm not telling you not to. And we're certainly going to be helping you get better if we can. There are times, though, that when the lungs eventually fail, that there is nothing else we can do to get it better. Are you aware of that?
Well, I didn't really think that far ahead.
No. It's important for me to talk to you about that, though, so that you have a sense of, what that might look like for yourself and for your family.
Well, I do know it's getting bad, but how far? I don't know. What do you think? What can we do?
So what we can do is make sure we try and improve your lungs, try and help your breathing as much as we can, and there is the palliative care team we can get to see you to get your breathing as comfortable as possible.
Yes.
I guess it's important for you to realise that if your heart and your lungs do fail, that you might die. It's unpredictable when that could happen.
It's a bit of shock, but thank you for telling me. I kind of know deep inside that this is happening. Yes.
So I know this is quite shocking information. The other important thing is you might have heard of CPR.
Yeah, I have, and I guess I was hanging on to that perhaps.
As a fallback, as a safety net.
Yeah.
So you were hoping that if we did CPR that things would be better?
Yes.
Most people think that. I guess the reality of the situation is when people are very sick from their heart and their lungs, CPR isn't particularly effective.
No, I probably realised that. Just was hanging on to the hope.
Hope's very important.
Yeah, it's been good of you to be straight with me, yeah.
Look, I understand that's not easy to take in. Look, if you have any questions at all about that, I'm here for you to ask.
Thank you.
I think cardiac arrest has to be the most gentle way a person could die. And people want often to die gently and peacefully. And so doing CPR potentially takes that away from them. So it's really important that if we're going to provide CPR, that it's what the patient wants, because we can maybe turn a very gentle dying into a very bad dying.
And an end-of-life discussion and even end-of-life consequences can be a joyful experience for all concerned. And if you are part of the equation and if you are part of the partnership, you get a chance to share that and feel rewarded and vindicated in your decision to enter into a career in medicine.
If you're in a journal club or a workshop, please be led by your educator. If you're alone, please reflect. Are the conversations done well or poorly? Has the ask, tell, ask or the nurse tool been used? How would you do things differently?
Mr. Thompson.
Good day.
Derek Ing, one of the specialists.
Oh, yeah.
Can I call you Joe?
Yeah.
Great. Should we have a bit of a chat?
Yeah, go for your life. Someone has to.
So, Joe, you've been in hospital for 10 days, I understand.
Yeah, too right. Well, how long am I going to be here?
Sure.
No.
Look, I'll get to answering that question if I can. As soon as possible, we'll get you out, hopefully.
Right.
Because we haven't had a chat before, could you just take me through the last 10 days or just even a bit before that? What's happened with you?
Well, I don't know. I just had a heart attack and they brought me in here and I've been here lying in this bed, taking the medicine and people come along and examine me and take my pulse and all that sort of thing, but I don't know what's going on, really. They haven't even fixed this cough.
Sure. So it sounds like things have been happening, but you don't kind of have a clear sense of, where it's going.
No, I don't know if anyone does, really. Someone comes in and does something and someone else comes in and does the same bloody thing.
Yeah. So it's a bit confusing or frustrating?
Yeah, I'd say frustrating, yeah.
So, look, I'm here to help. I'm one of the specialists in the hospital, as I said before, and my job is to try and get you, to work with the team, get you better and get you out of hospital.
Oh, when?
As soon as possible.
Right.
All right. I know you'd like to know an exact day. I'd like to be able to give that to you, but at the moment there's few things we need to get on top of.
Well, what sort of things you got to get in?
For example, the cough. We'd like to see you get a little bit better.
Oh, so would I.
Yeah. So look, we're going to keep working hard to get you better.
Good.
I think that's important for you to know. The other important conversation is really what your sense of what we should do if your heart gets worse. So I'm not saying it's going to be now, but potentially down the track.
Well, how would I know what you should do? I'm a bloody truck driver, not a doctor. What have you got to give me?
Sure. So I realise that a lot of people have a sense of CPR. So if you get sicker and sicker.
CPR. Oh, that's the stuff where they belt you in the chest.
That's right.
That works, does it?
Well, look, that's a good question. A lot of people think it works, but in the situation where the heart gets weaker and weaker with repeated heart attacks, when it comes down to the point where your heart stops, CPR is not effective.
And any other way of starting?
I wish there was, right. But there isn't. There really isn't.
So what else can you do?
When it comes time that your heart is not working, we would make sure that you're absolutely comfortable, free of pain.
Yeah, and I'm still here? Or at home? Can I go home?
Yeah, so these are different scenarios we're talking about. I know it's confusing. At this stage, you are improving and we are going to get you home.
Ah, well, that's something.
It is useful that we've had a discussion about this. And
if I get weaker and weaker, do you want me back in here or can I stay home?
I think that's a good point and we can discuss that.
And we have to discuss it with the missus as well.
Sure. How about we then get your missus in and we can talk about a plan at home as well?
Yeah, I think that's a good idea. Okay, so I'm going home.
Yes, you are.
Good.